that we have to recognize in a very deep way that when we do the work we do, whom we are trying to influence matters greatly. And over time, the ways in which we've done public health and global health and primary health care research, especially in the global south, has been to impress not a local audience, not the audience that is supposed to be the one taking decisions and reasoning with the result of the study, but an audience that is far removed.
Hello, and welcome to the Global Health Unfiltered podcast, a podcast about unspoken realities about global health in Africa and the world. I'm Desmond Jumbam, and I'm joined by my co-hosts Ulrich Sidney and Ella Amoako. Hey guys.
Hi Des.
Hi Des.
So today on this show, we'll be discussing equity in global health research, and we have a very special guest today to talk about this very important topic. So Dr. Seye Abimbola is a senior lecturer at the School of Public Health at the University of Sidney. So he completed his PhD on wide-ranging institutional analysis of primary health care governance in Nigeria from the Obafemi Awolowo University in Nigeria. He is also the editor-in-chief of BMJ Global Health and was named the Prince Claus Chair in Development and Equity at Utrecht University on Justice in Global Health Research. Welcome to the show, Seye. We're very happy to have you.
Thank you very much. It's very nice of you guys to have me.
So, Seye, we know you quite a bit from your work with BMJ Global Health as the editor-in-chief. And we also know you're very active on Twitter and a passionate advocate for decolonizing global health, if I can say that. But we would like to start by maybe learning a little bit more about you and your background. So can you tell us a little bit about yourself and your path to global health?
Thank you very much. I often wonder if I am in global health at all. Somewhere in my head, I'm not in global health. But I sort of recognize that when you sort of observe me from the outside, it seems as though he's a global health person. I feel in my head that I've never left Nigeria, that I've never left public health in the very traditional sense. So I was born and raised in a very sort of medical/academic family. My mother was a midwife, and which meant that I had a very early exposure to health and to primary health care, more importantly. And I went on to medical school, trained as a doctor, and worked for just 1 year as a clinician and immediately sort of went into public health. I did a master's in epidemiology and worked in the Ministry of Health at the national level in Nigeria. And then subsequently, I did a PhD also on primary health care because I worked at the National Primary Health Care Agency in Nigeria. So there's a line connecting pretty much my childhood to primary health care, to my PhD. And in a sense, I feel very strongly that much of what I'm doing now still is that public health, that primary health care. I don't feel I ever left those, and I'm not sure exactly what global health means or if global health is part of that or bigger than that. I've never worked that out clearly for myself or for other people.
So you say you feel like you've never left global health, but you're the editor-in-chief of BMJ Global Health, right? So, with the experience that you have now, how would you define global health, from your perspective, from your background that you've had, even growing up in Nigeria and practicing public health?
The reason I said I don't feel I ever left public health or primary health care is that I'm deeply convinced that one of the goals of public health and one of the rationale behind the idea of primary health care is equity. In other words, that what we are trying to achieve in those fields is reduce inequities. And I think that's what global health is trying to do as well. In my view, and the way that I understand it and use the word or the term, global health has to do with efforts, every effort, wherever, to reduce inequities, whether it is between countries or within countries. And when you sort of break that down, if the task of global health really is to reduce inequities, then it appears to me that, of course, there are other words, other terms, other expressions that speak to exactly the same thing, or potentially do, which is, of course, public health does that too. Primary health care, in many ways, does that too. Now, the idea, the coinage of global health perhaps does a few things more. One of them is that it includes the globe. It sort of, in a sense, makes public health global. But one of the things I struggle with is that in making public health global, there's a tendency for the term to then imply or suggest that only those who occupy spaces of power globally then do global health. Whereas if we were to interpret it, as I did earlier, as efforts to reduce inequities, that means that someone in a little village in Nigeria who is trying to improve women's access to care, or who is trying to reduce child mortality among people who are disadvantaged for some reason, they are doing global health too. Just as someone who sort of, for example, flies in from the United States into the Ministry of Health in Nigeria, trying to get the Nigerian government to agree to some global initiative on community health workers, is doing global health. So for me, the challenge really here is to not draw any false distinction between those two people. They are doing the same thing. And once we recognize that they are doing the same thing, it leads us into a different place entirely in how we think about what global health is and how it's done and how it should be done. And that for me is an important reflection, because I'm really keen to take over, to rescue, the way that I often describe it is to rescue global health from the hands of the global north. That it should not be something that only people in the global north do, but it's something all of us do. And once we recognize that all of us do it, then we have to think about it differently. If we retain its framing as something that foreigners do, that outsiders do, that people in spaces of power do when they go overseas, then it has a completely different meaning. And it's a meaning that I don't see myself reflected in, and it's a meaning that I don't identify with. So in a sense, for me to feel like I'm in global health, it has to become a different global health. It has to become a global health that I can identify with and occupy and feel like I'm a part of.
I really like how you put that. It, Someone at home in Nigeria who is trying to improve women's access should also be viewed as someone championing global health, as someone who flies into the country trying to improve access. It shouldn't be in the hands of those who have the money, as you put it. I really like that. I was airing my frustrations just before we started this, given there's a collaboration between two centers, and the center in the global north sits down and they would want to write up treatment protocols for people, for children who are suffering from a particular disease here, but they are not involving those clinicians that are in charge of these patients all the time. And to me, it was really frustrating, and I was airing that. So I like how you put that, Say. Thank you very much. Can you tell us about the concept of the foreign gaze in global health? Like, why do you think the foreign gaze is so prominent in this aspect?
There's a there's a quote that I like to repeat when I talk about the foreign gaze these days, and it was something said by a Malian literary scholar named Manthia Diawara, who said something like every narration places the spectator in a position of agency. In other words, whenever you write something or you say something, the person to whom you are saying it, the person to whom you are addressing it, you place them in a position of power. That they, in a sense, co-construct that thing you are saying or writing, whether you know it or not, whether you like it or not. Such that if I was speaking to you as I'm talking to you now, the way that I will address you will be different from the way that I will address a group of people from the WHO, even if I'm saying exactly the same, even if I'm trying to convey exactly the same thing. In other words, your audience has power. And because you are trying to reach them, you speak to them in a way that they understand, in a way that they like to be spoken to, and use framings that connect with them, use language that reaches them. And that's how I think about the foreign gaze. For me, the idea of gaze is the power of the audience to construct and influence how one frames a narrative. So if I was talking about a health issue in Nigeria, say in a small community, remote in Nigeria, health issue, malaria, for example, and I was addressing myself to, say, the district head or the local council chairman on that issue, the way that I will talk to them about the issue and address them about the issue will be completely different with how I will address a British Prime Minister or a British MP or someone who works for DFID or someone who works for USAID. The way that I will talk to them will be different to how I will talk to the Nigerian district head or local council chairman. Now, this sounds almost inconsequential when you hear it the first time, but the more you think about it, the more visible the impact is. Now, if I, as a researcher working in Nigeria, was trying to answer a research question that I believe is worth answering, will speak to the realities of Nigeria, what Nigeria needs to do in the next week, in the next month, in the next year. If I were to conduct that study, chances are great that the Lancet or the British Medical Journal will not like what I've done. Perhaps because it speaks to something very local, perhaps it uses methods that they don't think is innovative, perhaps because the issue just doesn't have resonance with the audience, supposed assumed audience of the Lancet or the BMJ, that it wouldn't work for them, typically. But if you were to conduct the same study, if you had conducted a study that was trying to do exactly the same thing in England, it would very likely, almost certainly, speak to the Lancet or the BMJ. And what I'm getting at here is that there's a way in which a researcher who is trying to do work in Nigeria assumes whom their audience is. Right? If their audience is the audience of the Lancet and BMJ, that audience then goes ahead in many ways to influence the research questions they want to ask. It also goes ahead and influences the research methods they choose to use, because they are no longer trying to impress that local council chairman or the district head. They are trying to impress some vaguely defined entity who sits somewhere in Britain. Now, very often, I don't think we researchers just yet appreciate the extent to which this shapes everything we do. Whom we are trying to influence then goes ahead in many ways to decide what we do, what we celebrate, what we value. And that's what I'm trying to get at with the concept of the foreign gaze. That we have to recognize in a very deep way that when we do the work we do, whom we are trying to influence matters greatly. And over time, the ways in which we've done public health and global health and primary health care research, especially in the global south, has been to impress not a local audience, not the audience that is supposed to be the one taking decisions and reasoning with the result of the study, but an audience that is far removed. And the reason for this, we must remember that the reason for this is that we were colonized. Now, again, that sounds rather trite, but the reason for that is that we were colonized. That for some reason, a journal that was created to serve England and Britain, we expect that journal, for some reason, will serve the world. It wouldn't. It cannot. But we've somehow come to believe, they've told us that. They've told us that the BMJ is for the world, or that the Lancet is for the world. They are not for the world. They will still serve the interests of their local communities, first and foremost. And for me, the purpose of every knowledge system is to help connect a system to more of itself. In other words, that you can't achieve that reduction in inequities, that the way that I define global health. You can't reduce inequities without that sort of organic connection within a system. It's that connection that actually allows change to happen. And when you look at the history of how health improved in much of the world, including in sort of pre-colonial African communities, including in Britain in the 18th century and 17th century, when you read the history of how health improved, it is through the growing local connection of systems within themselves, whether it is in terms of information systems or knowledge platforms or founding journals like the Lancet and the BMJ. That's how change happens. It is actually finding platforms and mechanisms and processes that help to connect the system within itself. Now, for some reason, over time, we've come to believe that that is not the most important thing when we think about research and generating knowledge and using it and circulating it. But it is. And until, in my view, for me, this is the most important thing that I want to think and talk about in terms of decolonizing global health. For me, to decolonize it is to own our knowledge platforms, is to ensure that we are serving ourselves first and foremost with how we use and produce knowledge, that we do not defer and outsource, in a sense, outsource our knowledge, our connection platforms to something foreign that cannot possibly serve us, that wasn't designed to serve us, and will never do. So that's how I think about it. That's what it means for me. This idea of the foreign gaze is the power of the audience to shape everything, and the ways in which our colonial histories has turned very wrongly, painfully wrongly, our attention, so that we are trying to impress an entity that has whose primary purpose is not to serve us in terms of helping to connect our system within itself.
To own our own platforms and the power of the audience to shape the knowledge that we receive. I mean, I understand that we need to own our own platforms, and we need to like lead, and that would bring us closer to owning these things. But sometimes, even amongst ourselves, there's this little rift that goes on, and is it possible for African scholars to fall prey to on the foreign gaze?
Yes, I think that is what exactly I'm talking about. That we have been educated to do that. I think we should not ignore the power of how we were educated in all of this. I'm not sure if you guys were educated this way, but I suspect you were, to think that whatever is Western is by virtue of being Western superior. To think that if you want, that if you are not on a Western sanctioned or Western approved platform, then you are nowhere. To think that your history did not begin until the West came to your doorsteps to steal, to plunder, to enslave, and to colonize. I think it's a big part of all of this. In other words, that what is really going on here, what I'm trying to get at here, is the need to decolonize our own minds, because we've been educated to think about the world in certain ways, and those ways mean that we are in many ways reenacting what the colonizers asked us to do. So when, for example, we don't look at ourselves as people who are just as credible, we don't look at our platforms as platforms that deserve just as much nurturing and support and value, that if we don't understand that our systems, health systems or other systems, require that we focus on them, that we pump our knowledge into them and generate our knowledge from them and for them primarily. If we're not thinking about ourselves in that way, then we are in a sense, deferring to the foreign gaze, or even constituting ourselves as that foreign gaze that others in our spaces have to defer. So yes, we get caught up in this. We are in this, and again, if we are to think about what it is, in my mind, to sort of remove this colonial influences from our minds, a good place to begin is to try and begin to re-examine what our assumptions are about the production and the use and the circulation of knowledge. What is it that we've been trained we should do, and how does that diverge from what we need to improve our health systems and to reduce inequities in health in our own spaces?
Thank you. And to your question about how we were educated, we're very much educated that way, from the little things like an accent. You're educated that if you get the English or the American accent, you sound a lot more sophisticated as opposed to using a traditional African accent. And then maybe if you're fortunate enough as you grow older, you learn that, well, there's not one English accent, and that the Londoner will probably think of himself or herself as more educated than someone from Yorkshire, or that the Bostonian will feel that they're more educated than maybe someone from the Midwest. And then a more complex level to what you're mentioning, which is when you start learning about research, when you start writing papers, you learn that you have to think about that audience and start learning about how the editorial body of that journal will read your paper and what they want to see. And that's how little by little you curate your paper towards a certain audience using a certain language and certain methodologies to get published in the so-called high impact factor journals. And like you mentioned, this perpetuates transformation, almost a transmutation of global health research, and definitely affects the research in the ways that you mentioned. My question now is regarding, again, the audiences in terms of journals, but also audience of grant and funding agencies. What would you say then is the way to make that switch from the current way we're writing and conducting global health research to a way that is more mindful of what's happening locally, and a way that is more equitable?
So there's something to be said for the influence of funders and of grant-making entities in perpetuating the foreign gaze. But what I'm often drawn to is just how much the funders themselves are only a reflection of whom researchers are. In other words, I think researchers like too much to point fingers at what is wrong about funders, forgetting that almost every priority a funder sets, almost every agenda, almost every request for application has had the influence of senior researchers, often senior researchers, in determining what it is the funder is asking. There was a recent funding call from the Gates Foundation. And apparently, I think they'd listened to a lot of people complaining about just how misaligned their funding can be with local priorities. So they sort of, in this funding call, said that, well, so this is for an innovation call, and they said, well, we want to hear from people who are local. In other words, we want local actors to be the ones leading the application. Which, of course, I was happy about that. Okay, yes, okay, a move in the right direction, local actors leading. And they added that they wanted the local actors to, in fact, propose innovations that can be scaled up. But, and this is the but they said, well, we don't want any innovation that already exists in the system. That whatever it is you are proposing has to be new. Now, when you step back and you ask yourself, but why would they ask such a thing? Because to my mind, almost every local system has those innovations that are just waiting for some support, or things that people have been trying for a long time. They know what they might do to make it work, but they don't have the resources. They don't have perhaps the ability. They don't have the connections, but the funding might enable that. That in fact, if you wanted something that would scale up, you probably want something that already exists in the system somewhere. In other words, you want people to look within their system to find ideas that they actually, think might work and might be scalable. But that a funding application says funding call says explicitly that, don't tell us something that already exists in your system. Now, that kind of idea, for me, again, goes back to the ways in which academics themselves have constructed the idea of what innovations are. If you go and read the papers of people who talk about innovations, there is this sense of thinking of innovation as something that comes from outside, that is not organic, that isn't within the system. So for me, when I think about the role of funders, I'm always reminding myself that whilst funders have their responsibility, they are more often than not a reflection of the academic community itself. That funders will not ask us what we don't think they should be asking us, ultimately. And when you look at how funders behave, if you look at all the quote-unquote wrong things that funders do, there are things they do because academics have said that is what they want. So whenever an academic says, well, the funder made me do stupid things, I say, well, other academics made funders ask you to do stupid things. So this really is a conversation academics have to have among themselves. So I'm always saying, researchers, look at yourself. Look at your colleagues. Look at how people were trained during their PhD and in grad school. What have they been told is the right thing and the best thing to do? More often than not, that is what then becomes what the funders ask you to do. When people champion, for example, the absolute supremacy of randomized controlled trials, and funders ask for it, and people who know that they shouldn't be doing an RCT, because the question that they are trying to answer, the need that they're trying to fulfill, does not require such. And in fact, an RCT would either be a waste of money or just an absolute distraction. When people know that, they still respond to calls for RCTs and promising RCTs, doing RCTs that are completely inconsequential. And that's not because funders themselves are messed up. It is because academics themselves have over time told funders that that's the only evidence that matters. So in a sense, I'm always concerned and interested in the ways in which a funder's agenda, or in fact the agenda of funders more broadly, not just one funder, are constructed such that they reflect what the dominant narratives and the dominant preferences of powerful academics are. That if funders and academics are cut from the same cloth, drawn from the same socio-demographic pool, they will keep asking for the same thing. That for me, the real challenge about funders is that, it is us. When I say us, I mean academics very broadly, and I mean academics who are global north influential, academics who tell funders what to ask for.
But I'm curious, editors also have a huge role to play in addressing some of these inequities that we're talking about. And I'm curious, when you were, appointed as editor-in-chief of BMJ Global Health, what was your thought process in addressing some of these issues that you're talking about? How do you set up a journal that really looks at this issue of, the foreign gaze or the misplacement of it, and, develops a journal that tries to address those issues, tries to, focus the gaze on the locales and the systems that are, most need the research. So can you take us through your thought process when you were, kind of setting up BMJ Global Health and the type of journal that it would be?
When I was appointed, I had a similar relationship with global health that I described earlier, which is that I'm not sure I'm in global health. I know that I'm in public health and primary health care. So this global health thing, how can I make it so that I can own it? And so for me, one of the earliest decisions I had to make was that I wanted a journal that a Nigerian working in Nigeria might be interested in reading. Not because they are wedded to the foreign gaze, but because they want to serve Nigeria. So that was perhaps where I began. And for me, what that meant at the time was that I wanted an editorial board where there were people who have a clear understanding of what it is to strengthen a system and what it is to ensure that people who are local to a space actually own their knowledge systems. So it was, in part, at the beginning, just thinking about what it would mean for a journal like this to not be owned by the Global North, even though it has British in its title and its editorial offices are based in London. I suppose the second thing I had to think about then was if this journal is going to serve the needs it's going to serve, then I'm going to have to be clear in how I write my opening of inaugural editorial about the goal that the journal was going to serve, which of course was when I had to then define for myself as clearly as I could what global health meant. And for me at the time, I sort of wrote that it was reducing inequities everywhere. Because for me, that was going to be an important factor in deciding which papers to accept, which papers to publish. And it also then meant, of course, that if it's about reducing inequities everywhere, a paper about, say, indigenous inequities in Australia or in Canada or in New Zealand or in the US or in parts of Latin America were global health too. And we publish papers from those places and on those issues a lot in the journal. So for me, it was going to be a journal that was about the world, global in terms of just being global. That it wasn't going to be a journal that was where people only wrote about lower middle income countries or the global south, that there was going to be a global journal. And it was from the beginning. And then the other challenge for me was the question of the article processing charges, which at the time, the rule sort of said there were countries that had 100% waiver and countries that had 50% waiver. And the challenge with that was that if you were going to claim 100% waiver, everyone from that on the paper as authors would have to have come from that particular country. In other words, if 4 authors were from Ghana and 1 was from the US, then you have to pay, even if the author from the US contributed only in a personal capacity and not necessarily the person who got the grant that supported the work, which in my view was counter a lot of potential collaboration in global health. And I did write an editorial about this, and eventually it's changed. Now that it doesn't have to be everybody, it just has to be more than half from that part of the world. So I've been concerned about just the potential inequity of such a journal, and I think it's gotten better over time. I'm not sure it's where I wish it was, but I don't have a lot of power to change a lot of things, including the money part of it. I can only campaign and argue and cajole, which I've continued to do. Now, the other part, I think, of making sense of how to approach what I did with the journal was also then thinking about what the role of a global journal should be. So I began thinking, in a sense, I began with the enthusiasm that a journal like BMJ Global Health could in fact serve globally. In other words, including serve Nigeria and serve Ghana and serve Cameroon and serve, local spaces in different parts of the world. But the more I worked on the journal over the years, the more it dawned on me that a journal like BMJ Global Health just can't do that. Even if you tried to, even if you did everything possibly could. Just because, as I've described earlier, just because it's still a foreign distance journal. And it wouldn't be able to do that. That in my view, Nigeria, Ghana, Kenya, pretty much every country, every space needs its own platforms. Now, it doesn't have to be journals, although it might be journals too. Needs its own platforms, needs its own mechanisms for circulating knowledge, for connecting within itself, that BMJ Global Health can't possibly do. Now, at the very most, at any given point in time, BMJ Global Health has about 90 to 100 manuscripts under consideration. That's a lot of work. And if the journal was going to pretend to serve the role of the Nigerian Medical Journal and the Kenyan Medical Journal and the Ghana Medical Journal, if you were to serve all of that, it would have about 100,000 manuscripts at any given time, which by virtue of being foreign will dilute, will misrepresent, will do all sorts of things to the knowledge processes within specific countries. So what I'm trying to say here is that over time, I've progressively lost the conviction that BMJ Global Health can serve local spaces, and grown in my conviction that one of the ways in which we can even out the academic landscape, one of the ways in which we can remove the foreign gaze, one of the ways in which we can, in fact, decolonize academic global health, and one of the ways in which we can actually help improve the functioning of our health systems is to have local journals and local platforms for knowledge exchange and circulation. So I've come to believe that very strongly, and I've come to lose over time my conviction that BMJ Global Health could be or should be as important. In fact, in my view now, when I think about what ought to be the case, I don't think BMJ Global Health should be more than 5% or 10% as important as it currently is. And the same goes for every other global journal, Lancet Global Health plus Global Public Health, or any other journal that is global in its supposed remit, should, in my view, begin to recognize just how limited such a platform is to serve the purposes for which it's been created, as it were, or the purposes for which we wish that it would serve. I'm not sure if I've told the story as well as I could, but just that over time, my thinking has changed. I began, in many ways, from a place of trying to use the journal to achieve equity, which I think, to some extent, at least in terms of the journal serving the role of foregrounding certain conversations in global health, has been successful. But at the same time, recognizing over time that even if it was doing all it could, as best as it could, it couldn't possibly serve some functions really well. That some functions are, by their definition, local. And the continued importance and emphasis on these global platforms are in some way a distraction from what it would take to strengthen those local platforms in different places and parts of the world, without which actually we don't get the kind of progress that we are really looking for.
That's a very interesting point, and I've had the same conviction myself for a while. The idea that we need to strengthen, our research capacities, but also our platforms for disseminating research and knowledge in Africa, in low and middle income countries, in the quote unquote global South. But the obvious follow up question would be, how do we do that? Because there are incentives that make it hard for, imagine a young, global health researcher. There's all these impact factors. You want to publish in the Lancet, you want to publish in the BMJ, you want to publish in these, renowned journals, right? And that maybe prevents them from publishing in their own local journals. So the obvious question, Shay, is how do we strengthen our local dissemination platforms, our local journals? How do we do that?
First, by being convinced we need to do it. I don't think most of us are convinced just yet that we need to do it. And so for me, a first step is actually getting as many people as possible convinced that we must do that we have no choice but to do that. And if we're convinced that we need to do that, we will do it. I was recently interviewed by someone who was doing consultations for a big global health funder, trying to decide what they should fund, what priorities they should support. And again, this goes back to my earlier argument that a lot of what these funders do go back to what prominent academics tell them they should do. So they were asking me what they should fund. And the only thing I said, and I made sure that it was the only thing I said because they wanted me to say more, but I refused to say more, was to go and fund local journals, go and fund local information systems. Those two things, just do them. And if you do them, they are, the way I described this idea to these people was that they are interventions or they are programs that will trigger the agency of people to do different things that you can't even begin to imagine. But that often we meaning global health funders and academics, we're often interested in interventions that will do things for people, not necessarily unleash their agency. And I'm saying, go and ensure that this, people's platforms help them connect with themselves, first and foremost. And if you do that, just wait and see what they will do. Trust their agency, not go and give them another, set of things that you've always given them and hasn't changed things very much. So first is, to be convinced that we need to do this. Second is to convince people who want to support global health, whether locally or internationally, that they need to invest in it. I've not heard of any, funding agency whose focus is doing this, is working on these kinds of knowledge platforms, for example. I think we need to get to that stage where we are convinced ourselves, we convince funders that they need to invest in this. And I think the third point to make here is also that when you look at take Nigeria or Ghana, for example, a very large proportion of Nigerian or Ghanaian researchers are not incentivized for impact factor. Those of us who are, we are incentivized because our eyes are so completely set on the foreign gaze. If you look at our local spaces, now that is why predatory journals could be successful. It is because in many local spaces, researchers' attentions are not on impact factor. And for me, I'm always sort of on one side. I don't like when people attack predatory journals. I know that they are predatory; they should be attacked. But I don't like when people attack it because in some way we who attack them do not own our responsibility in their existence. In that we have subscribed to a system that excludes most people, and then when those people who are excluded go about doing things that they ought not to do, we then criticize them and the people who are serving, who are filling the space that we've left, for being bad. Right? So there's a part of me that, wants to say, if you want to criticize predatory journals, criticize yourself too, that you have subscribed to a system that excludes the vast majority of people. But the second way in which I approach the idea of predatory journals is to say, there's such a gap, there's such a huge space that exists in these systems. What if we fill that space with legit local journals? What if? And what if we did that with the recognition of how much agency that act of filling the space can generate within a system, whether it's in terms of of a different way of writing papers, of communicating research, whether it's a different way of even approaching what is to be valued and celebrated as a research study or design or finding within a particular space, which doesn't necessarily have to be the same in Nigeria and the UK, or in Nigeria and Ghana. There could be different things in those places. But the recognition that that space exists, and it's strange that this space has existed and been clear to us for decades now, but we've not done anything to fill it. So yes, when you say that, but what if, what happens when junior researchers want to get into high impact factor journals? Yes, some do, but it's a very small percentage of junior researchers who want to. When you look at the entirety, that there's a large proportion of people who just don't know what to do and who are struggling to get into this rarefied high impact factor spaces, when those spaces may not necessarily be for them or be good for them. Again, going back to the idea of the foreign gaze, when you do a piece of study that is very, that is speaking to local realities in a very direct way, that study will very likely not appeal to the Lancet or the BMJ. I keep using those two examples, but I'm using them to represent the vast bulk of high impact factor Western journals. That those Western journals want to hear things that, about specific interventions, things that are little and tiny, but speak to their tastes. And I suppose the way I'm approaching this is to say there's a whole space in the local that need to be filled, and we need to start to innovate to fill those spaces.
Yeah, I mean, you've touched on so many points there. I have to agree with you 100%. Local researchers, the majority, are not headed for, or are not gunning for the high impact factor journals. That is a fact, and it is really interesting that you mentioned working on these local information systems, because one of the things I've noticed in Africa, for example, is that if you're thinking about knowledge production, there are so many theses, dissertations in African universities that are done by students, healthcare professional students, and that never see the day, or that never get shared widely. And so we even find ourselves in this space where sometimes some of that foreign gaze research is actually is just duplicating things that already existed, or that when we conduct these systematic reviews and trying to get a good sense of what's happening locally, and we say we don't have information from a certain area. The funny thing is, if you go to the big universities, if you're going to University of Lagos, if you're going to the University of Ghana, if you're going to the University of Kinshasa, and you head to the library, you just take the thesis and dissertations, you will end up with a very large amount of information. And I really like that you insist on that fact, because it's important that we find ways to make this information available, because then we're creating this agency you mentioned, not only for creating information for a local audience, communicating for that local audience on that purpose, but also changing that narrative, bringing that information to the funders then that this is research that is worth funding. I really appreciate that. And I think this is, again, related to what you've mentioned about decolonization. Sorry. In a recent piece you co-authored with Professor Madubai from the University of Toronto, you both suggested that global health may not survive its own decolonization. I mean, what do you mean by that, not being able to survive its own decolonization?
Talking about just knowledge systems and journals and knowledge production and research so far. And what I'm hoping has happened in the course of this conversation has been to show just how different how we do things could be. Just how different. I mean, you were giving an example just there about the kinds of knowledge that exist, say, within the library of a university that are not on PubMed, for example. But you could say exactly the same thing about the kinds of knowledge that exist in a community that is assumed to not be there. There are studies that people conduct, and I look at them and I'm like, God, no, you didn't talk to the people in this community, because if you did, this wouldn't be your research question. You'll be asking a completely different question. Or when you read a paper and sort of someone says something like, we conducted this study to fill a gap in the knowledge because we had conducted a review and we realized that, this XYZ is not known. And I'm thinking, no, XYZ is known. It's just not known by PubMed. If you go and talk to people, they know it. And just imagine what that does, for example, for even how we write a research paper. If someone were to say, for example, that your introduction should not just be a quick literature review, but also a discussion of what knowledge existed in the space in which we were conducting the study. What did the people know? And then move from there to say, what were they doing with that knowledge? And then move from there to say, what were their learning needs, given what they were doing with the knowledge? What else did they want to know? And then say, okay, I am conducting this study because they wanted to know ABC. And then that is your study. Now, I'm just giving an example of just a research paper, how you even construct the introduction of a research paper. Of course, in this research paper, the other part of it also is different. Then your method is going to look different to the traditional one, and your discussion will look different, and your results will be framed differently. So I mean, and again, that's just one example of just a research paper. So I suppose what we were trying to get at with that line in that paper was that when we begin to imagine the kinds of things that will have to be different, the kinds of assumptions that we would have to relax or do away with completely. For example, of the centrality of a global journal, or for example of the absolute importance of specific interventions instead of thinking at the systems level. If you think of all the things that would have had to change about the field if it were to be decolonized, right? The field will look so different to what it looks today. It will look so different. And the slight joke when we were writing the piece was to say that it will look so different, we will want to call it a different name. Right? That it will look so different. And again, we don't know exactly what it would look like. We can only sort of glimpse at it through these examples that are a bit more concrete. But it will be very different, and that was what we were trying to do. To talk about, which is that what we think of as global health today is still very global north owned and oriented and controlled and directed. What if you were not so? What we think of today as our sort of academic system is still one that sort of places what the West knows or needs to know or wants to know as the center of everything. What if it were not so? What we think of today as what would constitute a proper intervention is very often an intervention that could sort of be replicated from one place to another because it's this grand intervention that the world loves. What if we were not so? What if each intervention, what if each community, each setting were to, have its own intervention strategies, solutions, calibrated for its own purposes, designed with its own participation? What would that look like? What we think of as research today still heavily prioritizes this idea of things being generalizable. And whilst generalizable is important for some kinds of knowledge, it is not important for the most kinds of knowledge that we are trying to generate and use and circulate in global health. In other words, what we are trying to get at is not so much that everyone believes the same thing or that there's one truth for everyone, but instead that there are transferable insights from one place to another. But what is true and applicable in one space is different from what is true and applicable in another space. There's a very common throwaway line in many systematic reviews that I've observed, which is to say, for example, it's about measuring things, that we need one standardized global measuring tool for XYZ. when I see that in the thematic review, it's a huge red flag. Because what it suggests to me is that the people who have done that have not thought carefully about what it means to measure X in space A, measure X in space B, measure X in space C. You can't have a tool for those three spaces. Those three spaces are not extremely similar. And we know that most spaces are not that similar. Again, so there are these assumptions that we bring into how we think about knowledge. That just suggests to me that we are far away from any place that might be described as decolonial. So if we were to imagine what it is to have a decolonized global health landscape, too many things will be different. I can't begin to imagine what they are. And that was the point we were trying to make in that article.
I just love how you're able to speak about these things, speak up about them. And it's probably not an easy position to be in, like your daily conversations with people, interactions with people, and you interact with people who have a certain mindset, and you have to work with some of these people. So I just want to know, with your work and the way you think and what you stand for, have you had any pushbacks? What do people who don't believe in what you stand for say? And how do you respond to their criticisms?
I mentioned earlier that every narration places the spectator in a position of agency. So I have different audiences, and I'm often aware of that. That there are people with whom I would have the kind of conversations that I'm having with you, because I know that you guys and myself are in many ways cut from the same cloth. We are very similar in many ways. I know when I'm talking to people who don't approach the issue from that same point of view, and I come at it from a different point of view. For example, if I'm talking to, say, very vaguely defined white people, I'm often also trying to make them see that they've suffered from colonization too. Many of them, they just don't know it. Or other forms of supremacy or of oppression that they have been brought up all their lives to not be aware of. Whether it's women, how women are treated in Western societies over time, up until today, or whether it is people who are LGBTQ people, or people who are indigenous people in Western countries. In other words, one of the things I'm trying to do at the same time is just show how global these concerns around equity and justice are. That they're not things that Africans and Asians only think or talk about or only have experienced. That you've experienced it too, just that you probably don't know it. There was this line in an essay by James Baldwin in the New Yorker from the 60s, where he sort of said that what white America does not know about me is what it does not know about itself. And what he was trying to get at there was just this sense that there's nothing, my history is your history too. And there was another place where Baldwin said something about how the racist oppression of America has destroyed white people as much as it's destroyed black people. In fact, in his argument, it's that it's destroyed white people more, because the destruction of white people is more far-reaching and it goes deep into their soul. That it's actually destroyed who you are and how you see yourself. And when I look at how America is today, I cannot but agree with Baldwin. There's something deep in the destruction of white people and white society in America. So anyway, so there's also that way of approaching the issue of sort of saying that this thing is not just me. If you understand your history, you will see that we are not very different. And that's a good place to start. But of course, these strategies don't always work. And there are people who, for example, whose argument against whatever it is I have to say is that, but why don't you talk about all that is good in that global health has done? That global health is not that bad. Everything is not that. Everything is not decolonization. Someone once said to me. And again, it's my task is to try and make them see that everything is in fact colonization when you examine the field really closely, or that whilst it's done some good, when you place that good within the context of all that has happened in history, it's almost inconsequential. Or there are people who also talk about, say, research, knowledge, and how there is that what we're talking about is going to mean that there's not one truth, or that it will be easier to say research is wrong or not reliable. And I'm always reminding people again that we have to be careful to make sure that people understand that there are different kinds of knowledge paradigms and research, and sometimes they all solve different problems. For example, I wouldn't want a drug that hasn't been tested in an RCT, but I wouldn't want you to present to me the result of an RCT of how to ensure that communities are organized so that they can demand their rights from the government. I don't want an RCT on that. An RCT wouldn't tell me anything about that I need to know about that. So again, so explaining those differences to people can be very useful. Another line of argument against a lot of what we are saying is that, well, the more you guys talk about decolonization, the more that it's anti-solidarity, that white people will just run away from trying to help LMICs or trying to ensure equity in global health globally. In other words, that there is something about the complaining about how colonial the field is that puts well-meaning, quote and unquote, white people off. And what I often think about when I hear this is something that the Nigerian writer Chimamanda Adichie once said about, I think it was in an interview, or she was giving a speech, I can't remember now, but it was a response to how men can be afraid of, self-assured feminists, women that men might want to run away from them. And she said, it is the kind of man that is afraid of that is intimidated by me, that I don't want anywhere near me. So in other words, this sense that if talking about coloniality puts you off, then you better stay off. Thank you very much. So there are all these, ways of experiences that I've had in terms of people challenging, and also me trying to make sure that I'm heard correctly, heard as clearly as possible, and that I make arguments that people in my audience find compelling, given that I'm often speaking to different audiences.
The quotes about Chimamanda it's perfect. I've had similar experiences, and Ulrich, Ella, and I were just talking about one question I was asked once was, who are the locals? And that was in response to my insistence that an intervention that we develop, the programs that we develop, be based on what the locals want. And so the question came to me, like, who are the locals? And it kind of took me aback. I thought, that's an interesting question. There were follow-up questions that were like, okay, well, are the locals the patients who need the service? Because if you go to, some community and you say, what do you want, right? The locals will tell you, I just want my child to be healed, or I just want this issue to go away. Or if you're talking about the locals who are the leaders within the communities, maybe they'll give you a different response. But if you talk about the public health experts and the policymakers, they'll give you a different response. But that question has kind of, really took me aback, because the question was not, I don't think, was honest in saying, I really want to figure out who the locals are to address the issues, to understand the issues. But the question was really a statement that our intervention that we have come up with is the solution to the direct issue that the patient or that mother of that child is facing, right? And so the point that you're raising is really powerful, and And I wonder, Shea, what advice would you give? Because you say it's not just that we who, at one point were colonized need to decolonize our minds. There are systems of education that have, put these ideas in our minds that what is white is superior. But there's also those who maybe are well-meaning, who are also colonized, right? Their minds are colonized in the way they think about, in their assumptions about global health, in their assumptions about what they know and what they're able to provide to the communities. So my question is, what advice do you have for young people, whether they're from the north or the south, in their approach to quote unquote global health? How should they? And I think about myself at University of Notre Dame, getting into a master's in global health program, not really knowing what a master's in global health was. Right? What advice would you give to these young people as they are thinking about a career in quote unquote global health?
Now, there's a lot that I could say, but I think something that has served me well, I think and hope, is just being very determined that I will not be educated out of what I know. In other words, that I will learn from whatever degree, unit, method, etc. that I'm being taught or I'm being made to learn, but that will not stop me from being whom I am, from understanding the world the way that I understand it, and from understanding what purpose ultimately I want whatever knowledge I acquire, whatever method I acquire to serve. So I suppose the first thing to say here is just being absolutely determined that you know what you know, and that you're from where you're from, and that you know what the problems really are, and that you will not be tricked out of understanding that because of what somebody told you at Harvard or at the London School or somewhere else. I think another thing to think about here, or perhaps to suggest, is the need to always find like-minded people, people who sort of share the same kinds of standpoint as you, who can help you see clearly what is going on in the world and what is going on in the field itself. Because very often what you find is that people slowly begin to lose what they know to be true because of how extremely valued and celebrated these Western systems and platforms are. I'm not sure I have much more to say. I think there's another point to make here, and it goes to your example of who is local. There is the way that I think about that is if the government of a local council in England was trying to do something about child health within their local council, who is local there? The government, the children, their parents, the school board. You can list a lot of locals, and they are all local. And for me, the better question is, how do you arrive at a solution from a conversation among these locals within that space that is then accountable to these locals, because the people who are making the decisions and who are involved in that conversation are all within that space together, and not someone who has come from, say, Paris or from Beijing to say, here, locals in local council of XYZ in England, here's the intervention I've got for you. And I think in a lot of global health, it is that thing, to just throw something in. Whereas in conversation, even when they disagree, even when they don't see the world in the same way, there can be a sense that we start from A, but in conversation, the intervention changes over time because people learn. I think we often forget when we think about interventions that they're almost always complex, and that with complex interventions, people learn. And the intervention today, if you come back in 5 years' time, it's a different thing going on in the system. It's changed. People have changed. People learn. And the real issue is to ensure that locals are in conversation with locals. Again, going back to the question of gaze. and of accountability and of local connection. Is that what is going on there is locally networked and connected. And again, back to the question of advice for perhaps young Africans, is to understand that what we are really trying to do ultimately is connect the system to more of itself. Pretty much, you can put a full stop after that. And anything that stops you from doing that, optimally, somehow, is distracting you from doing the right thing.
Wow. Thank you so much, Seye Abimbola. We've unfortunately come to the end of this very exciting episode. Thank you for taking the time to come and share your knowledge and wisdom with us. We really, really do appreciate it. For all of you, thank you for joining us in this episode. If you have any feedback, again, feel free to reach us at unfilteredgh@gmail.com, and you can also reach us at our social media handles. We'll be sharing a few links to Seye Abimbola's articles that have been referenced in this episode in the link in the description. So feel free to, again, reach out to him through his handles that we'll share on social medias. Seye Abimbola, thank you very much. It was an honor to have you on the episode.
Thank you very much. Thank you.